Okay, so I think I'll invite Dr. Heera Ram now. Dr. Heera Ram is Assistant Professor of Interventional Radiology at the Mahatma Gandhi Institute. He has trained in radio diagnosis at the Aurobindo Institute in Indore, followed by a fellowship in interventional radiology at the Medanta Hospital in Gurgaon. And his area of interests are hepatobiliary interventions and oncology interventions. He is a member of several Indian and international intervention radiology societies, and he's very active in terms of interventional procedures. So, Dr. Heera will be talking to us about the role of ultrasound, which is generally the first imaging modality one resorts to in the setting of a suspected liver space occupying lesion. So, over to you, Dr. Heera. Please share your screen and tell us about ultrasound evaluation. Thank you.
Before Heera starts his presentation, I have to add that although today he is talking on ultrasound, but his forte is interventional radiology, and he and Dr. Nikhil Bansal, his other colleague in interventional radiology, they are a very strong support to GI surgery, HPB surgery, and liver transplant. So we are very fortunate to have two very
capable
qualified, experienced, and expert interventional radiologists. Yes. Welcome. Welcome.
Hi,
thank you. Thank you, sir.
Yeah, please share your screen.
Thank you so much, sir. And special thank to Dr. V.K. Kapoor, sir, giving me this opportunity to speak on ultrasound role in the liver as well. Although ultrasound is a screening tool because it's readily available, it's cheap, and again, it's a very good modality to diagnose. It's a radiation free. So quickly, let's talk about the ultrasound evaluation of the liver as well. Now, already Dr. Anand sir told about the classification of liver masses. So I'm not going into detail of this. Liver lesions can be divided into cystic, solid, and then in the parasitic, non-parasitic, parasitic divided into hydatid, and then non-parasitic there can be simple cyst, there can be polycystic disease, there can be biliary cystadenoma. Solid lesions can be inflammatory, which include pyogenic and amoebic liver abscess, and in the tumor part, it can be benign or malignant. In benign, it can be hemangioma, adenoma, FNH, and in the malignant, it can be SCC or secondaries. Now, first, let's talk about the cystic lesions. In the cystic, the most common lesion we encountered again in the insidadenoma is the simple hepatic cyst. Simple hepatic cyst, usually they are small lesions. They don't cause any problem to the patient. They are asymptomatic, and they are on the ultrasound. If you see, they are well marginated with internal anechoic content, and you can't appreciate the wall. And because of the anechoic content, you can see there is a posterior acoustic enhancement. And on the CT, you can see CT or MRI part, I'm not going to talk, but you can confirm on the CT. But generally, simple hepatic cyst does not require further imaging if you are confident with diagnosis, and if you know that all the characteristic feature of simple cyst on the ultrasound are available. Although the simple cyst can be sometimes they are a big cyst, and they can complicate with internal hemorrhage, they can be complicated with superimposed infection, then definitely we require further imaging. But a typical simple cyst is small 2 to 5 centimeter lesions, and they are thin walled cyst. Now I am going to talk about the large cyst, and they have the spectrum of appearance. Here in the first image, you can see there is a large cyst with thin walled and internal homogeneous content and with posterior acoustic enhancement. That means the cyst has internal hemorrhage in it. In the B image, again thin walled cyst, well defined, but there are multiple internal septae in it. That shows that this is organized thrombus in the simple cyst. In the C part, which is virtually looks like solid lesion, but is well-defined lesion. So in this, on the ultrasound, we cannot say whether this is cystic or solid lesion. So this definitely require CT scan for further imaging. On the CT scan, you can see this is thin wall, well defined with internal cystic content in it. So sometimes cyst with internal organized clots look like solid lesions. So definitely then we require further imaging. Now next is hydrated liver cyst. Hydrated liver cyst usually in accidentally found in on the routine ultrasound. The small hydrated cyst does not cause any problems to the patient. Now, as the sir told about the garbage classification, I am going to talk about detail of the this garbage classification of cyst. In type 1 cyst is a pure fluid collected cyst which can be confused with simple cyst. But on the ultrasound, if you see the wall of the cyst wall is thicker than the simple cyst, as we know that simple cyst has imperceptible wall. But hydrated cysts are thick walled, although they are well defined with internal anechoic content, but the wall is thick. Type 2 has a fluid collection with the split wall and they are look like floating membranes. So on ultrasound, you can very well see the floating membranes. Type 3 reveals the fluid collection with multiple internal septae look like honeycombing. They have multiple daughters in it. So again, this is the classical finding of hydrated cyst, and you can definitely diagnose this on ultrasound. Type 4 has a heterogeneous echogenic patterns, and in the type 5, because of the wall has calcification, so on the ultrasound, they have the reflecting wall, posterior acoustic shadow on the in the type 5 of hydrated cyst. Now let's talk about the detail of spectrum of appearance of the hydrated cyst. In the first, which is the most common hydrated cyst appearance on the ultrasound, has thick wall cyst with multiple internal daughter cyst in it, which is the classical of hydrated cyst. Now, in the B image, you can see which is garbage type 1 is a thick wall with internal content. So, in the how you differentiate from simple cyst and type 1 hydrated cyst. So, you can differentiate the wall. Usually, simple cyst does not have wall; they have imperceptible wall. But in the hydrated cyst, you can appreciate the thick wall. On the basis of this, you can definitely tell that this is not a simple cyst. This looks like hydrated cyst. In the D image, again you see there is a mass-like lesion, but on if you see closely, then you can see there are a small ring-like structure in it, and on color Doppler there is no color on demonstrable color, and these all the mass-like lesion, they are all the debris in it, and on the operation, they came out to be innumerable scoliosis. In the image, you can see there is a well-defined mass with calcification in the wall, and there is posterior acoustic shadow. On the CT scan corresponding image shows that the wall is calcified. So again, you can see that this is most likely the hydrated cyst. In the G image, you see there is a calcified wall, there is internal finger-like projection in it. So this is again classical of hydrated cyst. In the H image, you can see there is a central punctate-like calcification with again wall calcification, thick wall calcification in the posterior wall and with posterior acoustic shadow. So these are the various spectrum of appearance of hydrated cyst. Next is
Excuse me, Dr. Heera, before you go off, and if you don't mind, maybe it'll be good to keep asking questions in between. At the end, we tend to lose track. So you've taught us
sir.
about the cystic lesions, but type 3 onwards, type 2 or 3 onwards, what you've shown are mostly have a solid looking appearance.
Yes,
There's
sir.
hardly any fluid. So hydrated cyst can be a differential for solid lesions also.
Yes, but if you closely look, Like this D image, although this look like solid, but if you closely look them, then they can have
Fluid component.
yeah, yes, and then ring like, and those all on color Doppler, no vascularity. If you see that there is a wall calcification, then you suspect that this is hydrated. But on ultrasound, we cannot give the final diagnosis. We
Right.
have to go for further
Differential.
imaging.
Differential.
Yes,
We have talked about cystic hydatid disease, that is Echinococcus granulosus, which is what we see in our country and
yes,
most parts of the world. I think
yes.
in Kashmir and in Central Asia, you also see the alveolar hydatid, Echinococcus alveolaris. So,
Yes.
would you like to say a couple of words or sentences about what is the sonographic appearance of the alveolar hydatid cyst?
So definitely they also have the on ultrasound we cannot say that this is alveolar or what, because the appearance looks almost similar, it depend on the internal content of the particular hydrated cyst. So this is
Right.
difficult on
It mimics
ultrasound.
the solid appearance, the type
Ye-
3, type 4, unilocular or multilocular, and more of a solid rather than a fluid component in
Yes,
the
yes,
alveolar
yes,
hydratids. Okay, sorry for the interruption. Please go on.
And also,
yes,
if I'm correct, they have a more infiltrating like appearance rather than a well circumscribed appearance.
yes,
Yeah, you're right.
yes.
Quite right.
Please carry on. Please carry on.
And this is the typical. I am talking about the typical hydrated cyst appearance, but hydrated cyst can be multiple. They can be in spleen, they can be in liver, and in liver there can be multiple hydrated cysts also, and then they can be disseminated also. So they have a variegated appearance. But most common hydrated cyst looks. I mean, if they have internal daughter cyst, then it's a classical finding. Otherwise, they sometimes difficult to differentiate. Now, talk about the liver abscess. Liver abscess can be, as Dr. Anand said, that can be pyogenic or amoebic, but on ultrasound, it's difficult to tell that whether it's pyogenic or amoebic liver abscess. So, etiology of liver abscesses can be from the biliary tract. It can be infection from the GIT spreading via the portal vein. It can be hematogenous spread via the hepatic artery, can be direct extension from an intra-abdominal infection. It can be post-traumatic and cryptogenic also. So now I'm going to talk about the ultrasound findings of liver abscesses. Liver abscesses sometimes give you the challenge to diagnose on ultrasound if patient comes early. So usually liver abscesses diagnosis in USG is just screening, but if you appreciate with the clinical finding with the ultrasound, then it's easy for us to diagnose. Liver abscesses can have multiple variable appearances. It can be hypoechoic, which is more common, but it can be hyperechoic if there is internal echoes. Some liver abscesses has gas bubbles if the causative organism is gas producing organism, and on color Doppler, there is absence of vascularity. This is how we differentiate it from the mass. Now, again, these are the spectrum of appearances of liver abscesses. In first and second image, you see this is the same patient image. In the first image, when the patient came to us, then this is ill-defined mass, hypoechoic, relatively hypoechoic lesion, but we can't say this is the liver abscess. Only the clinical symptoms can say that, okay, this patient comes with fever and right hypochondrium, pain. Then on ultrasound, there is, because there is no liquefaction in the abscess, so this look like solid abscess. But after 24 hours, there is partial liquefaction. So now we can tell that, okay, this might be abscess. And the other finding on ultrasound can be no demonstrable vascularity in the abscess. In the third image, again, is a mass-like lesion, hypoechoic mass-like lesion, which is compressing on the capsule and on the adjacent kidney. On color Doppler, there is no vascularity, but this look like mass. And again, this is the only screening part. Sometimes in liver abscesses, which are sometimes confusing, we need further imaging, which is CCT. So the classical finding of liver abscess is in the middle row. you can see there is a well-defined mass lesion with central liquefaction on the color Doppler. There is no demonstrable vascularity. In the image, again, there is a well-defined large lesion with heterogeneous internal content and liquefied content in it. And in the F image is complete liquefaction of the liver with well-defined hypoechoic lesion. In the lower line, you can see there's a large, well-defined hypoechoic lesion with internal multiple echogenic content, which is uh, uh, confirmed on the CT scan that this is the gas-forming bacteria which causes the air in the abscess. So, in the typical abscess appearance, it's easy for us to diagnose on the ultrasound, but in the atypical findings of the liver abscesses, it sometimes is challenging to diagnosis whether this is abscess or not. But if you correlate with clinical findings, then it's easy for us to diagnose.
So, I think, Dr. Hira, I think the other thing that probably is worth mentioning here is the multiple cholangitic abscesses in biliary tract disease or extrahepatic obstruction versus metastases. At times, you have a malignancy, pancreatic, biliary, gallbladder, along with multiple lesions within the liver.
So
So,
I'll
maybe you can
talk
say a word about.
metastasis. I'll talk cystic metastasis later in my slides.
Acha, okay, fine.
Yes, yes.
Then we look at it then.
Now let's come to next benign finding, which is polycystic liver disease. It can be associated with ADPKD and it can be sometimes isolated also. So ultrasound findings are, there are multiple, you can see on the ultrasound, there are multiple fluid filled round or oval cyst with sharp margins. And we will differentiate later from other cystic lesion in the liver also. So usually they are multiple, they are fluid filled, they are round, and they have sharp margins. And sometimes it may be difficult to identify vascular and biliary structure adjacent to the liver. So sometimes we require further imaging, I mean the CT or MR to differentiate. So this require differentiate from the hepatic cystadenoma. Hepatic cystadenoma differentiate from the polycystic disease by that they have well-defined anechoic content, but they have capsule in it. They have capsule and they have multiple internal septae. This is how we differentiate cystic cystadenoma, hepatic cystadenoma from the polycystic disease by the internal septation and the capsule. So this comes into the cystic lesions and cystic metastasis. I talk later in the metastatic disease. Now let's come to the solid liver lesions. First, we will come to the benign lesions. In benign, hepatic adenoma is more common. Specifically, the women who is taking the OCPs, young female patients, hepatic adenoma is more commonly found. On the ultrasound, the hepatic adenoma usually presents as a solitary, well-defined heterogeneous mass, and echogenicity can be variable. Again, it is challenging. It depends on the how much fat it contains. If the hepatic adenoma contain more fat, then it looks echogenic. If it contains less fat, then it looks isoechoic or even hypoechoic. So, in the 20 to 40% of the patient, the hepatic adenoma looks hypoechoic to the surrounding liver parenchyma, or approx 30% it looks hyperechoic because of the internal fat content, and sometimes because of the fat sparing, they have the hypoechoic halo. On color Doppler, it may show the perilesional sinusoidal vascularity. Here in the two different patients and two different images, we can see in the first image a well-defined hyperechoic lesion. And in the second image, you see there is a well-defined hyperechoic lesion with surrounding hypoechoic halo. That is because of the fat sparing. Now, hepatic adenoma, usually they are small, but they can be large and they can complicate with internal hemorrhage. Then we can face some challenges in diagnosis. In the first image, you can see a well-defined isotohypoechoic lesion with internal solid hypoechoic content in it. On color Doppler, no vascularity was found. In the second image, again, well-defined hyperechoic lesion with internal hyperechoic content. These both are patients who came with right hypochondrial pain. Patient when have these hepatic adenoma internal hemorrhage, then patient presents with acute right hypochondrium pain. On the CT scan, you can see that on the plain CT scan, there is a hyperdense internal content. On the contrast enhanced CT, you see there is no internal enhancement. So this is confirmed diagnosis that there is hepatic adenoma with internal hemorrhage. Another patient, you see there is a hyperechoic, well-defined hyperechoic lesion with a hypoechoic halo surrounding in it. And on color Doppler, you can see peripheral demonstrable vascularity. Next is liver hemangioma, which is a very common tumor of liver. They are incidentally found. They usually small, more than less than 5 centimeter in size. They don't cause any symptoms. If lesions, they can be large giant hemangiomas, and which requires even embolization. So here in the first image, you can see well demarcated hyperechoic lesion, well demarcated hyperechoic lesion, and in the C image, you can see large, well defined mass with hyperechoic content in it. So these are a classical finding of hemangioma, but hemangioma sometimes they can have cystic changes. They can be like atypical hemangioma, large hemangioma. Then we find very difficulties on ultrasound. Then definitely they require further triple phase CT imaging to differentiate, and they have very classical enhancement pattern on triple phase CT. They have peripheral nodular enhancement on a CT scan in the arterial phase. Then it's subsequently filling in. So they have centripetal filling in delayed phase.
Yeah, Dr. Heera, what would
Yes.
be the differential you would look for? You've showed us initially hypoechoic lesions and you spoke about them in the earlier slides. Now you have a hyperechoic SOL here, which you say is hemangioma. So is there any other differential for a hyperechoic single or multiple lesions in the liver?
Yes, sir.
that you'd like to
If
consider?
the lesions are well defined and usually hyperechoic, well defined small lesions, they are most commonly hemangioma. But the differential diagnosis is metastasis, echogenic metastasis. The metastasis which is hypervascular, they look if solitary metastasis, hypervascular metastasis, they look similar to this. But if we have primary, we know that this patient have primary, then we sometimes require further triple phase to rule out whether this is hemangioma or this is the METS.
Right. So then to differentiate between the differentials, you move ahead to second step imaging, which would be either CT or MR that we'll hear in the next presentation.
Yes, sir.
So it would be good that in the hyperechoic, you just let us, each one of them, you let us know the differentials, because
Yes.
I think a sine qua non, something that is only definitely a particular specific lesion on ultrasound are few and far between.
Yes, sir.
Maybe occasionally hydrated cystic, but the others you always have differentials for hypoechoic, hyperechoic solid lesions.
Yes, sir. Now next we'll talk about the focal nodular hyperplasia. This is also very common, and again this is seen in the women associated with OCP uses, and usually FNH are less than 5 centimeter in size, and they can arise from right or left from any lobe. The echogenicity of both focal FNH and its scar is variable. It may be difficult to detect on ultrasound from the adjacent liver parenchyma. Some lesions are well marginated and easily seen, whereas others are isoechoic with surrounding liver. Detectable lesions characteristically demonstrate a central scar, but unfortunately, the central scar seen only in the 20% of the FNH. The central scar may seen on gray scale sonogram as a hypoechoic linear or stellate area with the central portion of the mass. On occasion, the scar may appear hyperechoic. Doppler ultrasound feature of FNS are highly suggestive in the well-developed peripheral and central blood vessels. They have very pattern of the vascular, which is a stellate type of pattern. So here, these are the appearances of FNH. In the first image, you see there is a almost iso to hyperechoic. You see, it's very difficult to appreciate with the adjacent parenchyma. So it's iso to hyperechoic lesion, but you can appreciate there is a central hypoechoic hypogenicity. On the color Doppler, you see there is a very patternable demonstrable vascularity, which is stellate arterial pattern. In the C image, you see there is a hypoechoic lesion. So in the first image is iso to hyper. In the C image, it's hypoechoic. But on color Doppler, in the grayscale imaging, you can't say this is FNH. But as soon as you put the color, this is diagnostic feature of FNH. You see this is a stellate pattern of vascularity. This is only seen in the FNH. In this image, again, grayscale image, it's well-defined isoechoic lesion, and which we can't say what it is. It can be even hepatic adenoma. But once you put the vascularity on it, again, it's a diagnostic. It is stellate type appearance of vascularity, which is characteristic of FNS. The FNS differential is hepatic adenoma, and final diagnosis is definitely for the hepatic adenoma is FNH or biopsy. But in FNS, we can diagnosis is on the triple phase, and if the stellate pattern of vascularity is demonstrated on the ultrasound, then we can confidently say that this is FNH. Or
what you told us is what you've told us is that only in 20% where you have a clear-cut stellate scar on Doppler,
yes,
can the sonologist be fairly sure that this is FNH? 80% will be a differential of other solid lesions like
others like hepatic
adenoma.
adenoma. Yes, hepatic adenoma is most close differential to the FNH.
Right.
Yeah, but nowadays we also do contrast enhanced ultrasound CEUS. On the CEUS, the early phase arterial phase on in the FNH will enhance relative to the background lever. Typical focal nodular hyperplasia show early arterial centrifugal feeling. And CUS, I am not talking about in detail because Dr. Sanyukta will talk about the CUS and this CTMR findings. In the late arterial phase, they have centrifugal figure which is opposed to hemangioma and adenoma. This is how we differentiate hemangioma and adenoma from the FNH. So FNH has centrifugal feeling, but in the hemangioma and adenoma, they have centripetal feeling. And in the portal venous phase, they have sustained enhancement in the portal venous phase, as opposed to adenoma, which is wash out in the later phase. Here you can see in the CUS ultrasound images, they have a typical centrifugal filling. So this is all about the common benign solid lesions of the liver. Now comes to the hepatocellular carcinoma, which is the malignant lesion, most common malignant primary malignancy of liver. SCC can be solitary tumor, they can be multiple nodular lesions, they can be diffusely infiltrative. So, and they have propensity to the venous invasion, specifically portal vein involvement can be seen approx 30 to 60% of the cases, and more often than the hepatic vein. Hepatic vein also can be involved, but portal vein are more commonly seen. Ultrasound findings, the sonographic appearance can be variable. SCC can be solitary, they can be multiple, they can be small nodular lesion, they can be multiple large lesions, they can be solitary large lesion, they can be cystic, they can have large specifically large lesion, can have internal necrosis. So it's difficult to then diagnosis on the ultrasound, and they can be hypoechoic, they can be complex, they can be echogenic. If usually the if the SCC are less than 5 centimeter, they are usually look hypoechoic on ultrasound. Now, the close differential for hypoechoic lesions, I can say that benign lesions, but they have the malignant lesions. They have irregular borders. While on the benign side of the lesion, you can see usually solitary lesions, well-defined lesions. Then they have more common of towards differential diagnosis towards the benign lesions. But if we see a nodular lesion and have background CLD changes and background nodular changes, then can more likely they can be SCC. So clinical finding and the background liver parenchyma is important to make differential of SCC. Otherwise, by looking on ultrasound alone, it's sometimes difficult. So usually the lesions which are less than 5 centimeter in size, they can be hypoechoic with the liver. And if the lesions are more than 5 centimeter, and if the lesions are large lesion, they are very prone to have internal necrosis or fibrous changes. With time, they can have the changes. Calcification is very uncommon, so if virtually we can rule out if any lesion has internal calcification, then we can say that okay, this is not SCC, this is something else. This can be metastasis. Some metastasis can have internal calcification. Calcifications are very uncommon, but small tumors may appear diffusely hyperechoic, secondary to fatty metaphoresis or sinusoidal dilatation, making them indistinguishable from the fatty. So sometimes focal fatty infiltration also look like lesion, but on then these type of lesion definitely require triple phase to rule out whether this is the focal fatty infiltration or this is the infiltrative SCC. So these are the B-mode grayscale findings. If the lesion are smaller lesion, they are usually nodular lesion. They have round shape. Their border are usually well defined. They can have hypoechoic hollow surrounding it. But if the lesion are large lesion, they have irregular shape. They can be very poorly defined. Then definitely it goes in favor of SCC. On color Doppler, small lesion difficult to demonstrate vascularity, but large lesion can be have very good internal vascularity. They can have pulsating arterial flow in it, so we can demonstrate it, and definitely we can confidently say, okay, this is malignant lesion. And final diagnosis is definitely SCC can be diagnosed on triple phase CT scan, or other lesion need histopathological imaging, which we require biopsy. We usually do biopsies which are indeterminate or non-diagnostic on the imaging, even though in the CT or MR. Now these are the spectrum of appearance of SCC. As I told you, they can be small lesion, they can be multiple, they can be solitary lesions. In the first image, there are multiple small hypoechoic lesion in the background of CLD changes. This is definitely in favor of SCC. In the B image, you see there is a background CLD with multiple hypoechoic lesions. Again, in the favor of SCC. These are the cirrhotic lesion. In the cirrhotic lesions, sometimes it's difficult to find if there are multiple small irregular nodular lesions. They can be also the nodular changes of liver, which we can say they can be LR1 nodule or what. So then we require triple phase CT to finally diagnose. Okay, they are not regenerative nodule, they are SCC. In this image, as I told you that these lesions can be hyperechoic, like cystic, echogenic mets or SCC. And in the background, if we can't see any that much cirrhotic changes, but definitely it has changes. But this is mimicking of hemangioma. This requires triple phase CT scan to finally diagnose it, because on the ultrasound this can't. We can say that okay, this is SCC, this is not hemangioma, or this is hemangioma, not SCC, because sometimes it's confusing. This is solitary small lesion, well-defined lesion, echogenic lesion. So this require the further imaging. In the D image, we can say, okay, there is ascites, CLD changes, and there is a large hyperechoic lesion in favor of SCC. In the E image, we can again say large lobulated lesion with mixed echogenicity, and there are multiple hypoechoic lesions in it. Then this is also suggestive of internal necrosis, and this is definitely a malignancy. In the F image, we can see there is again large lesion, ill-defined lesion with central hypoechoic scar. So this is scar in the large lesion. But FNH is well-defined, usually small well-defined lesion. So this can't be FNH. In the G image, we can see there is ill-defined mass with there is extensively soft tissue mass in the portal vein. In the H image, there is ascites, nodule, CLD changes, and there is background CLD changes, and there is exophytic lesion, exophytic hypoechoic lesion. So this is again we can say that okay, this is malignant CLD changes with malignancy. In the eye image, again we can say that there is a large lesion with mixed type of echogenicity, and again there can you can see the background, the echotexture is coarsen. So this is in favor of SCC.
Heera, I think another 3 minutes because we'll have to.
Yes, sir. Yes, thanks. In again in the A image, you see there is a extensive thrombosis in the portal vein. There is a background CLT. There are multiple small hypoechoic lesions. On the color Doppler, you can see there is a aliasing vascularity in the lesion. So this is a PVTT. On the color Doppler, you can see there is arterial enhancement in the portal vein. So this is definitely a PVTT, and it is confirmed on the triple phase CT. Now the final is metastatic liver disease. The most common primary tumor in the liver metastasis, they are from the gallbladder, colon, stomach, pancreas, breast, and lung. Most metastases to the liver are blood-borne through the hepatic artery or portal vein, but lymphatic spread can also be there from specifically from the stomach, pancreas, ovary, or uterus may also occur. The portal vein provides direct access to the liver for the tumors, which is originated from the GIT, and probably account for the high frequency because of the portal vein directly draining into the liver. Now, ultrasound features suggestive of the metastasis. There can be solid, multiple, varying size. They can be hypoechoic, halo surrounding it. If the lesions which are target-like lesion, then we can say that okay, this is metastasis. So, metastasis can be hypoechoic, hyperechoic, isoechoic. It depends on where it's coming from, whether the metastasis is vascular or is hypovascular or hypovascular. So usually hypoechoic metastases are come from the lung and pancreatic or esophageal tumors, and it also come from the breast. Here in the A image, you can see on the ultrasound, there is ill-defined large hypoechoic mass. And in the B image, again, large ill-defined hypoechoic mass. Now, if we don't know primary, then we can't say this lesion is definitely a metastasis. This can be a primary also. But if we have primary somewhere else and non-primary, then we can definitely say, okay, this is metastatic, definitely metastatic lesion. Now, they can be echogenic metastasis. Echogenic metastasis requires the differential from the hemangiomas. If we know the primary, then that echogenic lesion in the liver is in favor of metastasis more. And ecogenic can be from the origin from the GIT, or they can be originate from SCC also, because they have more vascularity. That's why they looks ecogenic on the ultrasound. And other ecogenic can be metastasis from the RCC. RCC, as we know that RCC metastases are very hypervascular. From the neuroendocrine tumor, they can be from carcinoid, they can be from choriocarcinoma or isolate carcinoma, also tend to be hyperechoic. Here there is spectrum of appearance of hyperechoic lesion with halo. In this you can say that this is metastasis, because this is hyperechoic lesion with hypoechoic halo surrounding it. Hyperechoic lesion with hypoechoic halo. So these are the lesions which can be confidently say, okay, these are the look like metastasis more commonly. But definitely for the final diagnosis, we require the sampling of the lesion and ISC marker for the further treatment plan also. Here in the other images, you can see there is a background cell with multiple small lesions. So they can be primary from the SCC, but also they can be metastatic from the other organ. Especially in the C and D image, you can see there is a large hypoechoic lesion with halo, and they are metastatic from the known case of breast metastasis. Now, metastasis can be calcified also. They are distinctive from their marked echogenicity and distal acoustic shadow. If calcification, there can be a distal shadow. Usually, the mucinous adenocarcinoma of the colon is most frequently associated with calcified metastasis. Calcium may appear a large echogenic and shadowing foci on ultrasound, and more common show the innumerable tiny punctate echogenic without clinic shadow. Other primary malignancies that give rise to calcific metastasis are endocrine pancreatic tumors. They can from the leiomyosarcoma, adenocarcinoma of the stomach, neuroblastoma, osteogenic sarcoma, chondrocarcinoma, ovarian cystadenocarcinoma, terracarcinoma can be calcific metastasis to the liver. Now, finally, cystic metastasis, they are very uncommon and generally exhibit features that distinguish from the benign hepatic cyst. So these are very confusing lesions, but benign hepatic cyst does not have mural nodule, but cystic metastasis can have mural nodule, and by that we can say, okay, this can't be the benign hepatic cyst. This is something to do with some metastasis. And benign hepatic cysts have thin wall, but cystic metastasis have thick wall. They are again fluid filled and they have internal septations. Primary neoplastic with cystic components such as cystadenocarcinoma of the ovary and pancreatic mucinous are often cystic metastasis to the liver. These are the spectrum of appearances of the metastatic lesion. From the top, you can see there are multiple small echogenic lesion scattered in the liver parenchyma. So there are echogenic metastasis. In the B image, you see there is a hyperechoic mass with internal punctate like calcification with posterior acoustic enhancement. In the C
I think
image,
you will have to summarize because we are encroaching on other speakers' time.
Yes, sir. This is my last slide. This is my last slide, sir.
Just please complete it quickly.
Yeah. Thank you, sir. So this F image is a large poorly differentiated metastatic adenocarcinoma which shows the tiny internal calcification. In the G to I image, there are cystic lesion with, you can see there is internal mural nodule in it. So we can say that, okay, this is cystic metastasis more likely than benign cyst. Thank you.
Okay, thanks, Dr. Heera. That was a very exhaustive and comprehensive coverage. You showed us a lot of images and told us how to do the ultrasound-based differentiation. I think if we have time at the end of the presentations, maybe we'll
I have some questions, but I think we'll move on because it's Sanyukta's time now. Yeah.
Thank you, sir.
So maybe Dr. Kapoor.